Okay, I think we're at 12 o'clock now. So hello everybody and welcome. This is the first of a series of 4 LGBT History Month talks brought to you by the Nottingham and Nottinghamshire ICS. So that's the Nottingham and Nottinghamshire Integrated Care System, where with partners we are celebrating LGBT History Month. And the aim of LGBT History Month, as you know, is to celebrate, to educate and to inspire. And we've got a wonderful presentation today from one of the colleagues from the trust where I work. So I'm Catherine Concha from Notts Healthcare Trust. We've got one of my colleagues, Nikki Rushing, who's here to talk to us today about exploring LGBT health inequalities around smoking, alcohol and drugs. And Nikki will introduce herself, but she's from the Trust Healthy Choices team. Over to you, Nikki. Thank you.
Thank you, Catherine. Let me just pop the share up for everyone. Okay, so welcome everyone. Thank you very much for coming. I really do appreciate it. My name is Nikki Rushing and I am the team leader for the Healthy Choices team at Nottinghamshire Healthcare. The talk that I'm doing today is exploring LGBT plus health inequalities with a focus on smoking, alcohol and drugs. This talk has been done in collaboration with Dr. Nat Thorne, Catherine Concha and Robin Naylor, and they are here today to help answer any of the questions that you may have. The Healthy Choices team deliver the prevention programme, which is part of the NHS long-term plan. We focus on reducing smoking, obesity and alcohol intake. And our service aims to help our patients and staff to stop smoking, maintain a healthy weight and make sure their alcohol intake is within healthy limits. While researching these subjects, I came across the LGBT plus report by Stonewall. As a bisexual woman myself, it contains some shocking figures in that national and local data suggest that alcohol, drug misuse and smoking within the LGBT plus community is considered to be higher than other populations. 1 in 6 LGBT plus people, 16%, said that they drank alcohol almost every day over the last year. Smoking prevalence is higher among lesbian, gay and bisexual people than in the general UK population. The data from Stonewall showed the frequency of alcohol consumption also increases with age. A third of LGBT plus people aged 65 plus say they drink almost every day. This rise can be seen quite clearly on the chart to the right. This does correlate to the health surveys Nottinghamshire Healthcare have carried out at Nottinghamshire Pride. There is very little data on alcohol consumption, specifically among those who are trans. Concerningly, however, the Scottish Trans Alliance found that 35% of trans respondents to an online survey said their drinking was problematic at some point in their life, and nearly 4% said they consumed 6 drinks or more daily or almost daily. The Institute of Alcohol Studies tells us that people in the LGBT plus community experience higher levels of depression and suicidal ideation. Both suicidal ideation and depression are known to co-occur with risky drinking. A systematic review by the BMC Psychiatry Journal found that the LGBT plus people were over twice as likely to be alcohol dependent compared to overall populations. Specifically, gay men were 1.5 times as likely to be alcohol dependent, and lesbian and bi women were 4 times as likely to be alcohol dependent. In recent years, alcohol producers have begun to market products with the rainbow flag and to sponsor pride parades in a multitude of cities. Some examples you can see here. The Institute of Alcohol Studies feels a deeper look into alcohol marketing and targeting of the LGBT community will inform the types of alcohol policy responses that are needed to reduce harm in this community. Data increasingly shows a disparity in the prevalence of smoking within the LGBT plus community when compared to a general population. In 2018, the Office of National Statistics found that the proportion of current smokers was significantly higher in people who identified as gay or lesbian at 23.1%, or bi at 23.3% than from straight people at 15.9%. And the similar data is shown here in 2019. There is a lack of research on smoking amongst trans people, but surveys from ASH do show trans people are more likely to smoke, and young LGBT plus people are also likely to smoke and start smoking at a younger age and smoke more heavily. Nottinghamshire Healthcare holds a stall and conducts surveys at the Nottinghamshire Pride on health needs of the LGBT plus community. The data for 2018 smoking prevalence is shown in this slide. As the Pride survey is a sample of a self-selecting group, it may provide an imprecise estimate of the true smoking prevalence for all who attended this event. While the research on smoking prevalence amongst trans individuals is limited, smoking estimates have been shown to be high among trans women. Trans individuals who are smokers may be especially vulnerable if they use cross-sex hormones such as estrogen and androgens, as this increases the risk of heart disease, and smoking is also shown to hinder recovery from surgery. Many trans people demonstrate resilience in the face of societal oppression. However, studies have documented a greater prevalence of many other social substance use and mental health problems that may enhance smoking behaviours and serve as barriers to smoking cessation for trans women. LGBT plus people are more likely to suffer from mental health, and smoking cessation is associated with reduced depression and improved quality of life. And this is why we need a patient-centred approach for those in the LGBT plus community. The LGBT plus people are disproportionately affected by wider social inequalities, which can increase the risk of smoking initiation and tobacco addiction. In 2021, the Youth Homeless Report showed that young LGBT plus people are more likely to be homeless. With this in mind, research carried out by the Homeless Link suggests as many as 77% of homeless people smoke. These two vulnerable communities need our support. The Crime Survey for England and Wales 2016 showed gay and bi men were more likely to have used drugs in the last year than straight men. 1/3 of the gay and bisexual men had used drugs in the last year, and this was approximately 3 times higher than the proportion of straight men who had done so. Reported use of all stimulants was approximately 5 times higher among gay and bi men, than among straight men, with methamphetamine use around 15 times higher. Evidence that the use of some specific substances is concentrated among gay and bi men, in particular GHB, GBL, and methamphetamines. Likewise, the rates of drug use are higher among lesbian and bi women than among straight women, 22.9% and 5.1% respectively. Studies conducted outside the UK for trans women have shown a higher prevalence of drug use than the general population. Poppers are a liquid chemical which are sold in small bottles. As drugs go, poppers are widely regarded to be harmless, hardly even drugs at all, but they are drugs, and probably one of the most commonly used by gay and bi men, due to their historic use in the LGBT clubs to give a short, sharp head rush high, and their ability to help relax anal sphincter muscles. They were originally used to treat angina and were never intended for recreational use. Poppers should never be swallowed as they are toxic and can kill, and mixing poppers with alcohol can also increase this risk. If you take Viagra or any other blood pressure medications, poppers can cause your blood pressure to drop to dangerous levels. Those with heart problems are even at risk of death, and fatal sudden sniffing death syndrome has been reported due to the development of an abnormal heart rhythm when taking poppers. Poppers are usually sniffed, although some prefer to dip the cigarette into the popper's bottle and inhale through the cigarette. Obviously, it's important to be careful due to the fire risk. So why? The reasons behind this are complex and could be due to many factors, and can even be more complex when considering LGBT plus individuals who are also a part of other minority groups, for example, BME and or disabled groups. Contextual factors are likely to include the fact that many traditional LGBT plus venues focus on or include alcohol consumption. In addition, these safe spaces may attract people exploring or being open about their sexual orientation and or gender identity for the first time. Minority stress is also likely to be a factor, as people self-medicate with alcohol, drugs and smoking to cope with feelings of discrimination or rejection from the wider society. One survey found that stress was the most commonly cited smoking trigger among LGBT plus people. Neptune, the novel psychoactive treatment UK network, tells us that people in the LGBT plus community are also more likely to use illegal drugs. High rates of smoking are often found among those using other substances. So does age matter? Hostile environment that older LGBT plus communities faced at younger ages in the UK may have had a lasting impact on their health. During the 1980s, the onset of the HIV/AIDS epidemic had devastating impact on the health, well-being and social networks of LGBT plus people. Most people aged 50 plus were born at a time where male homosexuality was in effect criminalised, and where social and legislative conditions permitted discrimination across a wide spectrum of domains for men and women from sexual minorities. LGBT plus people report poorer health than the general population and worse experience of healthcare, particularly cancer, palliative care, end of life, dementia and mental health provision. This is attributed to social inequalities, including minority stress, associated health risk behaviours, loneliness and isolation, anticipated experienced discrimination, and inadequate understanding of needs among healthcare providers. Data from 2017 found 20% of men living with HIV in London smoked. This was significantly higher than the general adult population. HIV positive smokers are more likely to develop cancers of the lung, anus, mouth and throat, and are more likely to suffer from respiratory diseases. In regards to alcohol and HIV drugs, we know liver disease such as hepatitis are an issue, as a healthy liver is needed for patients to benefit from HIV drugs. Heavy drinking can weaken the immune system and slow down recovery from infections. High levels of fats in your blood caused by alcohol can also cause potential harmful effects of some HIV drugs. Some anti-HIV drugs and some recreational drugs are metabolized by the same pathways in the body. The two anti-HIV drugs most likely to be involved in harmful interactions with recreational drugs are ritonavir and cobicistat. A dangerous interaction is possible between ritonavir or cobicistat and several recreational drugs, which are shown below. This interaction may increase the intensity of the effect of the recreational drug and sometimes to unpleasant or dangerous levels. Dr. Simon Deary, a sexual health and HIV doctor working at NUH, will offer his thoughts and reflections on how far we've come in 40 years of HIV. This will be on the 9th of December at 12 o'clock on Teams. Evidence in the UK relating to drug misuse among the trans community is almost non-existent. Studies conducted outside the UK show that trans women do have a higher prevalence of drug use than the general population. In the UK, there is UK and international evidence that the level of club drugs used among LGBT plus people and men who have sex with men in particular is higher than the general population. The European MSM Internet Survey, carried out in 38 countries in 2013, showed that the UK has higher levels of use of some drugs than do other parts of Europe. A combination of factors, including high-risk sexual practices and injection, have been described as the perfect storm for transmission of both HIV and HCV, as well as a catalogue of ensuing mental health problems. Three main drugs people take as part of CHEMSEX are methamphetamine, methadone, and GHB and GBL. Methamphetamine and methadone are stimulants, and people take by swallowing, snorting, injecting, or smoking. GHB and GBL are sedatives. GHB and GBL are usually an oily liquid that people mix with drinks and swallow. Risks increase further as 43% of CHEMSEX users have reported non-consensual sex. It is important to know that while the data on smoking, drugs and alcohol is disproportionately high for the LGBT+ communities, not everyone from these communities engages in these behaviours. Therefore, no assumption should be made and a patient-centred care should be practised. The Stonewall Health Report also reports other shocking inequalities statistics for the LGBT community in regards to the experience with healthcare services. 1 in 7 LGBT+ people have avoided treatment for fear of discrimination because they are LGBT+. 1 in 4 LGBT+ people have witnessed discriminatory or negative remarks against LGBT+ people by healthcare staff. And 1 in 8 LGBT people have experienced some form of unequal treatment from healthcare staff as they are LGBT+. We have to work at changing these barriers and make accessing our services easier and more accessible to LGBT+ communities. Such barriers can lead to disengagement from services altogether, which can have a severe and lasting consequence on an individual's health and well-being. While smoking figures in younger LGBT+ generations are on the decrease, which is good, there are still many gaps in knowledge around LGBT+ people, drugs and alcohol. More research is needed to represent LGBT+ communities to prevent alcohol, drugs and smoking harm and make services feel safer and more inclusive. Thank you for listening. I will hand over to see if there's any questions. Thank you.
Thank you, Nikki, for a fantastic presentation. But first of all, we've had a question from Benjamin, who's asked what date the data was taken in terms of the percentages figures given for the Trans Alliance population. Can you just confirm what date that was, please, Nikki?
For what part? Alcohol, drugs, smoking?
Sorry,
I will be sending the slides out. I can send the slides out, and they are fully referenced.
Okay.
For everywhere.
At the beginning, when it was saying that a lot of people had alcohol almost every day for the last year, I was wondering if that was a pandemic year or a pre-pandemic year.
That was a pre-pandemic year.
Oh, damn. Okay.
Obviously, with pandemics, we know that alcohol consumption in all communities has actually gone up. If it's been recently released, the data from the Office of National Statistics, in general, that the alcohol related deaths have actually gone up. Obviously, they haven't looked at the LGBT+ community specifically, but if we look at the reasons why for straight people alcohol consumption has gone up, then I think it's safe to kind of assume that in the LGBT+ communities where there's more stress, there's more anxiety, it would have gone up still. So it'll be interesting to see when all the data comes through from everyone, exactly how high it may be.
Okay, thank you.
So we're now going to open up the floor for any questions. So if you have got any, please raise your hands now. Okay, Laura.
Hello, thank you for that presentation. It was really interesting. You mentioned in it that there was no robust research into smoking in trans populations, and I just wondered if you had any insight into whether any studies were taking place or why you think that might be, and also any recommendations from any research that had been undertaken as to what we can do to improve access to public health services, prevention services, things like that.
Definitely. I know when researching a lot of the data for the trans population, most of it was American. There seems to be a lot more research and data, and obviously I didn't want to bring this to here because I'm trying to keep it more local. I don't know if we have anyone here that has thoughts on how we need to address all this. You're on mute, Lisa.
Story of my life. Nat, have you got anything that you may wish to add to that at all?
Yeah, I think that the research that has been done in this country, and in fact a lot of it that comes out of the Nottingham clinic that both Laura and I are actually sat in, it suggests that anxiety and depression are vastly higher in the trans community, and what often obviously associates anxiety, you know, self-medication to try and relieve it in some way, and as we know, quite often people do turn to things such as smoking. So I would still expect to see higher levels in the trans community, yeah, around here. And how we address the access, I think that again comes down to making sure that clinicians use the right language and that they understand about sort of asking pronouns, and you know, and making sure that there's more education in general about trans people. And I'm not just saying that because I'm the person who quite often does the training, but we do actually need a lot more training in this area, I think.
I think as well, for ourselves as the Healthy Choices team, we are looking at ways whether it's with the LGBT plus population or the straight population, people are a bit too embarrassed to come forward sometimes for help. They don't want to go to somewhere where their data could be used, or the shame of it. So I think we're trying to look at ways to make it more one-to-one, more lived experience, more of a safe environment for people to come. I think, you know, I think we need to look at and address these things definitely more. And as a team, myself and Lisa, we will be talking in general in regards, and obviously with Catherine and Nat, in regards to cigarette smoking, drugs and alcohol. So we are there for staff and patients more, and people feel like they can come to us all.
Thank you.
That's great. Thank you. Okay, Pete.
Excuse me. I think a few of you have answered some of the questions I was going to ask, but it was more about if we've got representatives from different trusts here and different organisations. Are there any good examples that people here could share of how they've, you know, worked proactively to try and break down some of the barriers to access to services and making it more accessible?
It would be good to hear.
It would be good to hear. And perhaps I know that Sarah Harding is on the call today, and Sarah chairs the Smoke-Free Leads for mental health across the UK. And perhaps, Sarah, this is something we could potentially pick up as a fact-finding as well in the next meeting. Okay.
Yeah, that's something I'm very happy to do, Lisa. Thank you.
Thank you. Okay. Nora? Nora, you're on mute. Hi, Nora. I think there might be some good old Teams.
Yeah.
Nora, we can't hear you great at the moment, but if you want to put something in the chat, we can hopefully respond to it from there. Is there any other questions whilst Nora's doing that? We'll just wait for that one to come through. Catherine?
While we're waiting for Nora to come through, I think one of the things that is useful, which everybody tends to practice, is the most important thing is to listen to your groups, to consult your patients, to talk with them. And although it doesn't relate to specifically to adults, it's partly a response to some of Pete's question, is about engaging with different people. So in CAMS in Nottinghamshire, we've engaged a lot with young people, used a group called MH2K, Mental Health 2000, and that's done a project, and a lot of things that young people want to see. They want the environment to be more welcoming. So we've got a rainbow crossing, which is due to go in place, which takes it away from being the NHS typical organisation. We still need the big sign outside that it says it's an NHS establishment, because that's the way we have to do things. But if the eye casts your way to the Rainbow Road, then that's the first thing a young person sees, then that's better. We've also making sure that the bike sheds and the benches are rainbow wrapped and the environment is accessible and friendly. But that's not about us imposing that on young people. These are about young people coming up with their ideas. And another thing that the young people have done is they've engaged with our chief exec in the chair, and they've had some seminars and conferences and stuff like that, so that the voices can be heard at the highest level. So although I know it's not people's normal practice, and I know that you'll be doing that, Pete, it's just to reiterate the point of listen to the people, because they're the experts.
Thank you, Catherine. That's great. Nora?
Yes, sorry about that. It's just Wi-Fi and everything else is not connecting properly. Yeah, I just wanted to say, first of all, thank you very much, Nikki. That was an excellent presentation. And it has to be the very first that I was at from the LGBTQs looking at the smoking and health equalities. So well done. And I don't think it should be done just during this month. And so thank you for that.
Thank you.
What listening to what some of you were just saying, I think we've all got probably the same questions and the same asks in relation to where we're at within our organisations. How do we support each other? Within the Cambridge and Peterborough NHS, yes, we've got loads of EDI champions, and yes, we've got loads of allies. But when it actually comes to doing stuff, it's very difficult to get people pinned down to actually stand up and say, let's do this, raise more awareness. It always seems to be the same people. So it's lovely to have this group today. Maybe following on from today, maybe we could have a continuing and on-group support, because we can learn from each other. Personally, myself within our organisation, when I ever share something, whether it's on Twitter, I always tag Nottingham in, because you do such good stuff. And we've shared each other's tweets. You might not know that. And somebody mentioned about other people who have built a lot of resources and really have done an awful lot of hard work. Is a guy by the name of Simon Pearson up in Northumberland and that. And they do absolutely amazing. I mean, it's took them a long time, but we are nowhere near that within our organisation. I can honestly say there's a handful of people that get together, but it doesn't represent the amount of people that come under that umbrella within our organisation. So I don't know whether it's out of fear. I don't know whether it's out of time, and some people feel they don't always be allowed to attend meetings, that's not a priority, and things like that. But in relation to the health equalities and listening to what you were saying within the presentation, you know, I work with mental health, so we've seen people come in that under the LGBTQ and the concerns they have and the fears, not just about their mental health, but their physical health as well. And I think that's really, really important that we're actually looking at that now. You mentioned about smoking. So I know there's a long-term plan. This year, I think, for the next 12 months or 2 years is smoking and pregnancy. I know Sarah Harding is here, and I've been at meetings with Sarah before, and smoking and mental health. So hopefully, looking at the findings and the research to do under that will be interesting if they do proper reports, and also if they put them into categories to see in relation to the research and the evidence you've done. But no, thank you for your invite today. I'll stop talking now, but it's a pleasure. Thank you very much.
Nora.
Thank you, Nora. That's great feedback and some really good positive ideas as well for going forward. So that's really good. Thank you. So we just respond to some of the questions that have also come up as well in the chat bar. So we've got a great, so Simone has actually put really interesting, thank you. Good to keep in mind when looking at smoke-free in hospitals. Absolutely, which is why we wanted to raise this as well, because it's really relevant with it, and to make sure that we bear in mind with our clients as well, for inpatients and community patients. And also, are you able to share the slides, please? Yeah, we will be doing that. Sophie, I think Nat's going to respond in terms of what does the training look like that you offer?
Yeah, I basically normally just start with a basic transgender language 101, where we go through sort of 10 words that people perhaps might think they know about trans people, but probably don't. Actually, they probably don't know the nuance and the depth of them. But we also look at language in action, and the main thing is, I think people don't use language because they're scared of getting it wrong, and they're perhaps scared of how the people react when they get it wrong, how they react. So we sort of discuss it, kind of gets you thinking a bit about how you can use better, more inclusive language day to day, but also if you do mess it up, kind of how you counter that. And I think when we're talking about this subject, I think, yeah, that's quite important as well. And the other point, which actually we haven't raised about smoking for trans people, is that a lot of the surgeries that trans people will have, they have to stop smoking and have to be able to kind of prove that they've stopped smoking. So actually smoking clinics, cessation clinics are actually really important to this community. So that's another place where if you can start with just the basics of pronouns on badges and you know, introducing yourself with pronouns and stuff. But anyway, yeah, that's the kind of sort of language tweaks I was talking about, really.
That's great. Thank you, Nat. Okay, so Jason Simpson-Theobald from Therapy Services has posted a question. Hi, I'm the HIV dietitian from NUH. I think using familiar language with patients, my research into CHEMSEX shows that using the language more familiar to patients is helpful. So, for example, slamming rather than injecting, partying rather than taking drugs, etc. It helps to break down those barriers. Plus, I think the LGBTQIA plus community needs to do more research and put the information out there. Absolutely. I think that's a really good point. Does anybody wish to comment on that?
Yeah, Lisa, I was just going to say that I completely agree with what Jason's saying. And I think, you know, you've spoken about young people and that sort of a younger age group, and, you know, the trans community versus the gay or lesbian community, for instance. Everybody will have their own nuanced language, and it falls on from what you were saying, that actually we shouldn't be afraid to use what in any other circumstance may not be the most professional language, but actually it's a language that engages the people that we're trying to work with. We have all sat in front of that GP probably that's gone off on a complete medical tangent, and we've gone, yeah, totally get that entirely. And actually we've not understood a single word they've said for the last 5 minutes. And what we don't need to do is do that with, you know, the communities we're talking about today, because you instantly turn them off from accessing services. So actually, you're quite right, Jason, using language like slamming rather than injecting, that's the language that is used by that person. Let's use that language back. And then that links back to what you were saying, that if somebody, you know, use the name, use the pronoun, use their own description of their sexuality, whatever it is, use that language back to that person, you're far more likely to get engagement and then continued engagement thereafter, because they'll walk away kind of thinking it's, you know, you've understood me, rather than just talked medical jargon at me for the last 10 minutes and I've nodded and agreed but not really understood it. So I think that is a really, really valid point, Jason. And it's often a difficult space to get into, to use language that we wouldn't routinely use. But, you know, that comes back to having some self-confidence, I suppose, a little bit, to let yourself go into that space and to learn and to understand. And so I can't remember who it was that commented after that. Mary, you said about you know, a session on language. Absolutely. If you don't know, ask. I think that's the really key thing. If you don't know what something is, somebody uses language or you come across something, just ask. You know, none of us know everything, and I think that that's really key to say. I'm really sorry, I don't understand what that means. Can you just explain it to me? Because again, that shows your willingness to learn and engage that community.
Thank you, Robbie. That's great. Gary has asked a question as well. What stops us as individuals asking the person in the moment to change or alter their language rather than walking away resentful?
Yeah, I wanted to say that, or ask that, or pose that thought, because I sometimes struggle with it. It often appears to be everybody else's fault. Apologies for the sweeping generalisation there, but you know, but I'm mindful of it as an individual. I identify as gay, and if there's anything, you know, language that I don't like, then you know, I appreciate you use the word there, Robbie, the confidence. Some people have, some people don't have. I'm confident to challenge. I'm confident to ask people to alter their language. I'm confident to ask, or you know, ask that my preferences are at least considered. And I just wonder, you know, for me to do that, I recognise, if you like, because it's me that needs to understand and or that it's affecting me, that I'm responsible as an individual to convey that message. So, you know, yes, generally, you know, everybody needs to be mindful. Again, another sweeping generalisation. You know, I felt I both needed to say / ask, you know, ask that in terms of us ensuring our needs are met. That makes sense.
Yeah, no, sorry, Lisa, don't mind me just jumping in. Gary, yeah, no, I completely agree. There is, you know, in an ideal world, I suppose we should all feel or have a degree of confidence to be able to speak up and say, actually, this is how I would like you to address me, or this is the language I'd like you to use. I suppose going back to the slide that Nikki you put up about the number of people who don't feel confident to talk about who they are with a professional, and the research does clearly show that LGBT people are far less confident to talk about themselves, but also that health professionals don't see the relevance of sexuality and gender when it comes to care delivery, and that research is quite clear. And I think those two things put together, not having the, I'll use the word confidence, but you know, generalizing, don't have the confidence to speak up as an individual out of fear of you know, pushback or not understanding or not having a welcoming environment, those kinds of things. And then you meet that head on with health professionals that don't see the relevance of it. That mixed together can be quite toxic in terms of being able to access and have those very open conversations. And I think that's part of the issue, is that the knowledge hasn't been shared necessarily with health professionals in the way that, you know, we maybe share safeguarding, or we share things around the deaf community, or you know, those kinds of other areas of equality in the same way. And I think, like I say, that mixed with a perceived lack of confidence, it's the age-old thing. If you're on a ward and you've been admitted because you've broken your leg and you're not happy with the care, you don't complain till you've left, in case, you know, you don't get pain relief, you don't get offered food and drink, you know, that perception that if I complain, my care will actually get worse. And I think that plays into it. Nat, I don't know if you or Catherine, if you want to add sort of anything to that around sort of experiences you've come across in terms of people feeling confident and that speaking up thing.
Yeah, I'll come with this a bit. Yeah, I think particularly for my actual expertise was originally in non-binary identifying people, and I think that particularly for non-binary people, there does seem to be research suggests that actually standing up for your own pronouns and things like that is something people quite don't often do, actually. I'm myself, I'm very guilty about that, even though I'm arguably becoming quite a, you know, well known as being non-binary in all areas of my life. You know, I still don't stand up for myself, and it takes my partner or my friends to say, actually, not users, are they them? And I think that, yeah, that presents in itself a bit of an access issue, and it's just so, it's almost like a big, huge, comfortable chair when you go and see a professional who already comes preloaded with a bit of information, and it's not complex. It's not, we're not asking for everyone to learn every single kind of, you know, drug users language, every single sort of HIV related language and trans language, but there are some key words that if you can just use them, it just shows that you're at least understanding, or that you're, you know, receptive, because a lot of people won't correct, I don't think, incorrect language. It's, yeah, even right back in the day, I didn't even correct people about pronouns of my partners, because people assumed obviously I was straight, because we did back then. Even then I didn't correct, and that situation might happen as well even today. So yeah, so I think language is important, because we often don't stand up for it ourselves.
Thank you. Gary, has that answered your question?
Yes, it has. I just wondered then, with the discussion again, Robbie, you helpfully, you know, repeated maybe a lack of confidence, and that, you know, recognizing the difficulty you know people have. I just wonder if there's something we could do for each other to help that confidence, as opposed to say, you know, just leave it as fact that there is a lack of confidence. Actually, us as a group recognizing a lack of confidence, is there then something we could do? I don't know what that something is, but, you know, taking that, you know, a thought for something somewhere further down the line to, you know, look at how we support each other to be able to do that, as well as ask of other people to be open to.
Thank you, Gary. Catherine, did you want to respond?
Yeah, it's a bit of a response to what Gary said, but also a bit of information as well. So there's a couple of parts. We, as a trust, decided for Hate Crime Awareness Week, one of the things we were going to do is we were going to put some adverts and some information out about pronouns and the importance of pronouns. And we specifically chose Hate Crime Awareness Week because of all the misnaming people and all that sort of stuff, and actually identifying it as some sort of hate incident when it's deliberate. So we're trying to raise awareness of that. But the other thing, there's two other parts to it as well. First is that in Notts Healthcare, as well as the wider integrated care system in Nottingham and Nottinghamshire, we've relaunched the LGBT forum, and that's certainly some of the things we're looking at, Gary. So if you want to be part of that, there are some members of the group, Amy, Ashton and Aston, who are on the call this morning, who are part of the Notts Healthcare leadership group. We've also got Giles Matzo from Nottingham University Hospitals, who leads EDI for the ICS along with myself. And one of the groups we've got is the LGBT group. And we're looking at how we can improve things across the system. But the last thing I was going to say is that we've recognised that as a key issue, Gary, particularly around other people not speaking up for others when they know it's wrong. So some of the training that we've had delivered so far is based on a concept of no bystanders. And we've started off with the racism training at the moment, but some of the sessions that we're doing are things like Stand By Her, which is about sex discrimination and misogyny, but also LGBT issues as well. So that'll be coming out pretty soon. But that's about not being a bystander, not just for hate incidents and hate crimes, but when anything is used to try and correct people in a sensitive and appropriate way. So hopefully that helps a little bit.
Thank you, Catherine.
Lisa, sorry, just before we move on, I'm really sorry, just to follow on from that, to pick up on Gary's last comment, and this is going to sound like an ideal kind of gold standard world, but I think sometimes some of the simple stuff can be some of the most empowering. So as an example, obviously yesterday, 1st of February, start of LGBT History Month. For those of you that don't know me, I cover the forensic division as the EDI lead within Notts Healthcare, which includes Rampton High Secure Hospital. So yesterday I wore the brightest rainbow t-shirt I could possibly find and walked around Rampton Hospital, and the amount of people who went, "Why are you wearing that?" in a kind of, you look slightly weird, but also in an inquisitive way. And actually they've invited me to a conversation. So that's allowed me to go, well, it's LGBT History Month and this is what it's about. And there's stuff on to, like, obviously it was yesterday, tomorrow, this session, there's, you know, other stuff throughout the month. There's information up in the staff canteen. There's lots of stuff happening. Do you want a rainbow lanyard? Sign up to the pledge to say, you know, you're going to be an ally. And actually something super simple as wearing a pretty daft t-shirt, but walking around somewhere that can be quite insular has actually allowed me to open up so many conversations. And yes, that's me, and I'm the EDI lead, and you know, there's, I suppose you could say that's part of my job. But actually, the simple things like pronouns and email signatures, wearing rainbow lanyards, correcting your colleagues, or you know, if you hear your colleagues using language that isn't as inclusive or in a less inclusive way than they should be, actually just saying, actually, do you understand what that means? And this is what it means. Or, you know, I'm not entirely comfortable with the way you just used that language. Exactly what Catherine's just said, that not being a bystander thing. And I think sometimes getting some of the simple things right and really ingrained can then help you to forward that conversation rather than necessarily going in with the really complex stuff right from the start, and just embedding that culture of it's okay to have a conversation, but it's also okay to get it wrong and to ask and all of those other things. And I think that's a cultural thing that takes a really long time to embed. But things like the training and things help with that as well.
Thanks, Robbie. Giles?
Thank you, and thanks, Nikki, for your great presentation earlier. It's nice to see some familiar faces on here and people I've not seen for a long time. My point really was, it's hard to disagree with anything anybody has said. Was actually to get back on track really with the issue of health inequalities specifically. And I'm quite mindful that there has been some report commissions, particularly in relation to mental health, by the CCG, and that work is still to be progressed. Certainly over several years working in Nottinghamshire NHS, you know, we've had a lot of opportunities for engagement. There used to be the Nottingham Gay Guide, which was really great at one point, and QB is still going. And fortunately, some of our NHS services do provide copy and content for QB as well. I'm a little bit uncertain exactly what our health inequalities engagement strategy is in relation to LGBT plus community for alcohol, drugs and smoking cessation prevention. I just think we could possibly do more. The fact that I don't hear about it very much is something more we could do. And one of the things Catherine and I and inclusion leads over some years ago now was to develop a guide called In the Pink, which was around raising awareness of health inequalities, and that was primarily aimed at GPs and healthcare practitioners. We do want to get that document updated, but in the wider sense, it'd really be helpful to know what specific HEI work is going to be taking place, it's particularly in terms of engagement.
Yeah, it's a really good point. I think going forward, I mean, this webinar today has clearly highlighted the need for that work as well, picking that up again going forward, and certainly with that as well, with a long-term plan in terms of the alcohol and smoking elements of prevention. You know, it all aligns, but also there's such a huge need for it that going forward. I know that Nikki has been attending is it the AHA board, Nikki?
Yeah, it was the AHA. They had a webinar yesterday that I attended, specifically talking in regards to alcohol with Glasgow University. So the conversations are happening. You know, we just need to go forward with this now and really push, I think.
Thank you, Giles. Uta?
Yeah, no, it's really just something sort of with the sort of, I spent a lot of time before I did my current job in the NHS, about 20 years doing service improvement and change management. And there's something about where you need people to be, because I think within general our staff, you'll have different groups. You'll have the really knowledgeable, inside out, comes second nature, get updated. You'll have the sort of people who are interested and come to this. You'll have a large group which in principle think it's all great, but don't quite know how to do it. Like they're not, like which was mentioned before, about not being quite confident or having the tools. So maybe just being a bit awkward, but good willing. And then you probably still have, like in the general population, a group who actually think, I treat everyone the same, it's not an issue, I don't know why they're fluffing about again. You know, that, so I think is maybe something when you think about strategies is how, yeah, so the different things for different people almost, but also the aim is, I suppose, to get everyone to a point where they actually understand it. Because I went on this similar seminar on another topic a couple of weeks ago, and I was asking questions as in, because I didn't have the understanding. I was saying, well, why is that even relevant there? And it wasn't because I was saying it's not relevant, but because I felt I can't challenge it with someone else if they just bat it back. I need to have a bit of knowledge. So that was one thing, you know, to have sort of build up the confidence of the majority, and then it'll spread quicker and they'll get more confident. But it's also that, yeah, so I think, you know, there's most people I would say are good willing, but don't quite have the confidence to challenge. And I think it's not fair to think a patient should challenge, really. I think we should challenge each other when we hear it, or we hear something, or someone, you know, you're allowed to ask that conversation or say, oh, I think it might have been better, or did you realize you were doing that? So it's our job, really. I think patients are very vulnerable, and when I was ever a patient anywhere, you don't say boo to a goose in case they think you're an awkward thing, you know. So I think it's our job, really, you know. So yeah,
it's a really good observation, and yeah, absolutely. Has anybody else got anything that they would like to respond to that? Yeah. Okay, is there any more questions before we close? No? Okay, Catherine, the floor's over to you.
Thank you, Lisa. So I'd like to thank Nikki, first of all, for her really inspiration. It engaged a lot of people, answered a lot of questions. Also to Lisa for chairing the session and for doing the Q&A, and to all of you for being part of it, whether through asking questions or just simply being here. The more people we can share this information with, the further we can spread it, the better care we can give our patients, and also the more care we can give each other. So thank you very much. And Lisa, how can people get a copy of the slides?
Okay, so we've got everybody's email addresses from circulation list. We will probably we can send a copy out to everybody on the circulation list. That isn't an issue. We can get that done.
Okay, that's great. So thank you everybody for joining us. Just as a reminder, there are 3 other events delivered by the Nottingham and Nottinghamshire Integrated Care System, hosted by our different organisations, and I've put them in the chat. I've put them in several times, but the joining links are there as well. If you can't access them, then please do get in touch with Lisa, and I'm sure she'll be happy to send them out with the slides.
Not a problem at all. Thank you all for coming and attending today.
Thank you so much, everyone. Thank you.
Thank you.
Thank you. Thank you.